Welcome to Paals. It's Prof Anyanwu's anatomy lecture series. In this place, our goal is to make anatomy simple. If you're just joining us or you have not subscribed, we'd like you to please subscribe now and be part of this amazing anatomy family where we make anatomy simple. This lecture is on the gross anatomy of the diaphragm. In this lecture, we'll be discussing the features of the diaphragm. We'll look at the components, origin and insertion, and also we'll look at innervation, and we'll close by considering some of the associated clinical correlates. So let's go to class. The diaphragm is actually a muscle that has two parts, a muscular part and a tendinous part. That's why we say it's a musculotendinous muscle, and it separates the thorax from the abdomen. So we have the abdominal cavity below the diaphragm, and then we have the thoracic cavity above the diaphragm. So this muscle is also called the thoraco-abdominal diaphragm or the thoracic diaphragm. It is actually the principal muscle of respiration. This muscle will be seen to be having two major parts. In this section, we'll be having this central whitish part we are viewing here. This part is called the central fibrous part, which is also called the central tendon. So here is the central tendon part of the diaphragm, and then we have these brownish looking areas, and these parts will form the peripheral muscular part. So this is the muscle area, and then this is the tendinous area. Because we have a number of structures passing between the thoracic cavity and the abdominal cavity, we'll be seeing a number of structures piercing the diaphragm. As soon as we look at the diaphragm, the first striking thing about the diaphragm is its shape. The diaphragm has two domes, one on the right and one on the left. And these upper curvatures are also called cupola. So here in this diagram, we are seeing the right curvature of the diaphragm, which is called the right dome or right cupola. And then here we're seeing the left curvature, which is called the left dome or the left cupola. Now the upper part of these curvatures we'll be seeing for the right, we'll be seeing at the upper border of the fifth rib, while the left dome, its upper part will be seen at the lower border of the fifth rib. By this, it is clear that the right dome of the diaphragm is at a higher level than the left dome. And this is as a result of the lever that will be seen lodged immediately below the right dome part of the diaphragm that actually gave rise to the higher elevation of the right dome than the left dome. Now, in between the right dome and the left dome, we see a lower part, which is the central tendon part. This part can be seen at the level of the xivisternal joint. So here where my light is the xivisternal joint, and the upper part is the body of the sternum, and then here is the xiphoid process, and this is the xivisternal joint. In this other illustration, we can see the clear higher right dome, we see the very low central tendon, and we see the left dome at this point too. Now, when we look at the diaphragm from various views, we tend to have different shapes depending on the views we are looking from. Now, we have three major views we use in describing the shape of the diaphragm. We have the frontal view, we have the side view, and we have the view from above. So we'll start with the frontal view. Already the view we have in this illustration is the frontal view. In this frontal view, we'll be seeing the diaphragm to be having the two raised curvatures convex superiorly. That's the right and the left domes. As we noted earlier, the right dome is higher than the left dome. Now, it's also noted that in full expiration, the right dome can go as high as the fourth intercostal space. Now, the level of the central tendon, which we had already noted to be at the level of the cervicsternum, when traced posteriorly, can be seen at the level of the T9 vertebra, or depending on the classification we're using, the intervertebral disc between T8 vertebra and T9 vertebra. So here at the right dome, we'll be looking at the upper border of fifth rib. In full inspiration, we'll be looking at the fourth intercostal space. Here at the central tendon, we're looking at the cervicsternum or body of T9 vertebra, or we want to say intervertebral disc between T8 and T9. And then at the left dome, we're looking at the lower border of fifth rib. For the side view, when we view the diaphragm from the side, we'll be seeing a shape that will be like that of an inverted J. Now we'll be seeing a shape like this, where we'll be having a short limb and a long limb. Now the short limb will be seen here. This will be a short limb, and then this is a long limb. And then let us trace this in this shape. So a side view of diaphragm will give us this inverted J shape. Now the region where my light is running will give us the long limb of the J, and then here will be the short limb of the J. So the long limb will be seen extending from the upper part of the lumbar vertebra. These are the lumbar vertebra, and it will move proximally. Now the short limb will be the part that will be seen attaching at this cervicsternum. The next shape we'll consider is the appearance of the diaphragm when viewed from above. So when this is done, it will give us a kidney shape. So this is as a result of the vertebral column that is seen posteriorly, and this is in conformity with the oval outline of the body wall, which is indented posteriorly by the vertebral column. Our next focus in this lecture will be the boundaries or extent of the diaphragm. Now here in this illustration is the outline of the diaphragm. Here is the anterior part, and here is the posterior part. So anteriorly here, we'll be seeing the cervicsternal junction. So the anterior border of the diaphragm is the cervicsternal junction or cervicsternal joint, and then posteriorly the border is the T12 thoracic vertebra. Now at the sides, we'll be seeing the ribs and costal cartilages. The diaphragm has three parts. These three parts are the central tendon, the right and the left crura, and the right and the left dome. Now let's identify these various parts. If we start from this illustration, here we see this part of the diaphragm that picks origin from the lumbar vertebra, both on the right and on the left. This is the part of the diaphragm that is called the right cross, the left cross, and both right and left will form the right and left crura. Now this is the right cross, and here is the left cross. For the central tendon, we had already noted this part of the diaphragm to be the central tendon. And now the third part will be the right and the left domes, which we have already identified. So in this other illustration, we can easily pick out the right cross and the left cross. We can also pick out the central tendon at this point, and then we can also pick out the right dome and the left dome. The next point for consideration will be the origin of this muscle. The diaphragm being a muscle has origin and it also has insertion. Now the origin is from three parts. We have origin from the sternum, we have origin from the costal parts, we have origin from the vertebra. So we have sternal origin, costal origin, and vertebral origin. So we go to each of these origins and identify how they picked their origins. We'll first consider the sternal origin. Now, the sternal origin is actually from the posterior surface of the xiphoid process. Now, this is the xiphoid process. The diaphragm will arise from the posterior part of this xiphoid process by two fleshy slits. The next part of origin will be the costal part, and here is the costal part. This costal part will be the inner surfaces of the lower 6 ribs and also their costal cartilages. And they will pick origin from both the right part and the left part to form the right dome and the left dome, respectively. The final part is the origin from the lumbar region or the vertebral region. That's the vertebral part or the lumbar part. Now we have the origin from the lumbar part arising as the right cross and also the left cross. For this origin from the right cross, we'll be seeing the origin coming from upper tree lumbar, as you can note from here. And this will be the origin that will be forming the right cross of the diaphragm. For the left cross, we'll be seeing it picking origin from the upper 2 lumbar and moving proximally. In addition to the vertebral origin or lumbar origin, we also have the extension of these origins on the thickenings of the fascia that will be covering the muscles that are adjacent to the vertebra. So we'll be having the medial arcuate origin, the lateral arcuate origin, and also the median arcuate origin. So we have these ligaments that are adjacent to the right and left crura. Those ligaments are the medial arcuate ligament, the lateral arcuate ligament, and the median arcuate ligament. They form part of the areas of origin for lumbar part. For the medial arcuate ligament, here is the right cross of the diaphragm, and lateral to the right cross of the diaphragm will be seeing the thickening of the medial arcuate ligament, and this is the medial arcuate ligament. So the medial arcuate ligament is the thickened upper margin of the fascia covering the anterior surface of the psoas major muscle. We have considered the psoas major muscle and the other muscles that will be seen in the posterior abdominal region in some other video that we have also released to all our students. So if you're interested in details on these muscles, you can look for any of these videos and then get more information. So here is the thickening of the fascia covering the psoas major muscle here, and that thickened part of the fascia is called the medial arcuate ligament, and the diaphragm is seen also picking origin from this medial arcuate ligament. This medial arcuate ligament will extend from the side of the body of L2 vertebra and will rise up to the tip of the transverse process of L1 vertebra. In this other diagram too, we're seeing here is the right cross of the diaphragm and here is the left cross. And here we'll be seeing the medial arcuate ligament and then this the lateral arcuate ligament. While the medial arcuate ligament is a thickening of the psoas fascia, the lateral arcuate ligament will be the thickening of the fascia covering the quadratus lumborum. Now, while here is the psoas major muscle, here is the quadratus lumborum, and then here is a thickened area of the fascia that will be covering the quadratus lumborum. So this fascia also will give origin to the diaphragm. Now, this fascia will extend from the tip of the transverse process of the first lumbar vertebra and will extend to the lower border of the 12th rib. The last of the arcuate ligaments is the median arcuate ligament. Now, between the right and the left crura is the median arcuate ligament. So the median arcuate ligament will join the right and the left crura. Here is the right cross and here is the left cross, and coming above them here is the median arcuate ligament. The median arcuate ligament will be seen crossing over the opening of the abdominal aorta here as it enters from the thoracic cavity into the abdominal cavity, and this will be seen at the level of the T12 thoracic vertebra. In this illustration also, we are seeing the median arcuate ligament at this point, and here is the opening of the abdominal aorta, and that's the right cross, and here is the left cross. Before we leave the origin of the diaphragm, we'll consider the contribution of the diaphragm in formation of the opening of the esophagus. The opening of the esophagus will be seen to be at the level of the T10 thoracic vertebra. We'll consider that in details in the following slides. But at this point, we'll be seeing how the right cross will cross over the midline to the left part of the midline to form a round sling that will transmit the esophagus. Here is the right cross. It will move across the midline and then form a round sling that will transmit the esophagus. So here is the esophagus, and here is the loop that is formed by the right cross of the diaphragm. And this loop will act as a sphincter and will possibly assist in prevention of regurgitation of the stomach contents from the abdominal part of the esophagus to the thoracic part of the esophagus. We will now consider the insertion of the diaphragm, having looked at the various points of origin. Now, the diaphragm is inserted into the central tendon. We can recall that here is the central tendon of the diaphragm. This central tendon can be seen to be having three components. Sometimes we say it is trilobar in shape. So we can see the right part here, the left part, and the middle part. So this is the right leaflet of the central tendon. Here is the left leaflet, and at the center here is the middle leaflet. The middle leaflet has a triangular shape that has the apex pointing towards the xiphoid process, while the right and the left leaflets are tongue-shaped, and the right being a little bigger than the left. We'll next consider the openings of the diaphragm. The openings we see in the diaphragm are actually major components of the description of the diaphragm. In these openings, we have openings we consider as major openings, and we have openings we consider as minor or smaller openings. We will take the major openings. In the major openings, there are three of them, and they transmit these three big structures: the inferior vena cava V, the esophagus O, and the abdominal aorta A, which gives us the mnemonic voice of Africa. These openings are at strategic landmarks in the vertebra. So the landmark for the inferior vena cava opening is at the level of T8 vertebra, while that for esophagus is at the level of T10, and that for abdominal aorta is at the level of T12. And that is what this illustration represents: inferior vena cava at T8, esophagus T10, and then the aorta at T12. Now, these big structures are not the only structures transmitted at these points of openings. We will consider other structures that are passing through these major openings. First, the caval opening. In our illustration, this is the cava opening, and that's the inferior vena cava, and we said it's at the level of T8. And here is the esophageal opening, and we said it's at the level of T10. And then here is the abdominal aortic opening, and we said it's at the level of T12. So what are those other structures that are passing through with them? At the cava opening here, we also see this opening transmitting alongside the inferior vena cava the right phrenic nerve. So the right phrenic nerve also passes alongside with the inferior vena cava. Now for the esophageal opening, we'll be seeing this opening alongside transmitting esophagus will also transmit the right and the left vagus nerves. It will also transmit the esophageal branches of the left gastric vessels and also the lymph vessels. The last opening here, that's the aortic opening, alongside transmitting the abdominal aorta, will transmit one big vein, the azygos vein, and also the thoracic duct. We will now consider the small openings in the diaphragm. We are now acquainted with some of the other parts of the diaphragm, like the right cross and the left cross. Now, each of the cross of diaphragm, that is the right and the left, will transmit these two nerves, the greater and the lesser splanchnic nerves. Now, while the left cross is transmitting the lesser and greater splanchnic nerves alongside the right, it will also additionally transmit the hemiazygos vein. So, the hemiazygos vein passes through the left cross of the diaphragm, while the azygos vein passes through the aortic opening that is seen at the level of the T12 thoracic vertebra. The next structure to consider is the sympathetic chain. Now, the sympathetic chain will be seen to be passing from the thorax to the abdomen behind the medial arcuate ligament. Now, this structure here shows the right cross here and the left cross. And the openings here are the openings for passage of the lesser and greater splanchnic nerves. Here is the medial arcuate ligament, both for the right and for the left. And we are noting that the sympathetic chain will be passing through this space. And here we're seeing the right and then the left sympathetic chains. The next structure to be passing through these small openings of the diaphragm will be the subcostal nerve and vessels. Now, while the medial arcuate ligament here was noted to be passing the sympathetic chains, the lateral arcuate ligament here on the right and then here on the left will be passing the subcostal nerves and vessels. So here we are seeing the subcostal nerve, the artery, and the vein. Now, the next structure to be considered in this section of small openings in the diaphragm will be a very important opening that is called the foramen of Morgagni or Larry's space. Here is Larry's space. So what is Larry's space? Now, this is a gap or an opening in the diaphragm that be seen between the xiphoid process, that's the lower part of the xiphoid process, and the seventh costal cartilage. And this opening will be transmitting the superior epigastric artery and vein. And then we'll also be seeing some lymphatics passing via this opening. The last part of the small opening is the opening that will transmit the musculophrenic artery and vein. This artery and vein will pierce the diaphragm at the level of the 8th or 9th costal cartilage. We'll be considering the functions of the diaphragm. As we noted at the beginning of this lecture, that the diaphragm is the principal muscle of respiration. So the first function we'll consider is the function of inspiration. On contraction, the diaphragm pulls its central tendon down and will increase the vertical diameter of the thorax. The diaphragm is the most important muscle used in inspiration. The next function is the function of abdominal straining. This muscle is also the muscle of abdominal straining. The contraction of the diaphragm will assist the contraction of the muscles of the anterior abdominal wall in raising the intra-abdominal pressure, and this action is very important in micturition, in defecation, and also in parturition. Diaphragm is also considered as a weightlifting muscle, and this is important in the action of making sure that there is a raised intra-abdominal pressure, which is part of the processes of weight lifting. And this is achieved by taking a very deep breath. In this condition, the diaphragm is fixed. In so doing, the diaphragm will assist the muscles of anterior abdominal wall to raise the intra-abdominal pressure. The last aspect of this function we'll consider is as a thoraco-abdominal pump. When the diaphragm decreases the intrathoracic pressure, it will lead to increase in the intra-abdominal pressure. The descent of the diaphragm will decrease the intrathoracic pressure and increase the intra-abdominal pressure. This will lead to compression of the blood in the inferior vena cava and forcing of this blood into the right atrium of the heart. And this action is considered as thoraco-abdominal pumping. Nerve supply of the diaphragm. The diaphragm is supplied by the right and left phrenic nerve. For sensory innervation, the parietal pleura and peritoneum covering the central surfaces of the diaphragm are from the phrenic nerve, and also the periphery of the diaphragm is supplied from the lower 6 intercostal nerves. In this illustration, we can see the phrenic nerve running down to supply the various parts of the diaphragm. Before we round off this lecture on diaphragm, we'll consider a few clinical correlates. The first is the role of the diaphragm in hiccups. Now, a hiccup is an involuntary spasmodic contraction of the diaphragm that will force air into the lungs. And as this happens, the glottis will snap shut, and this will lead to the making of the hiccup sound. Now, hiccup is a condition that is normal in individuals and usually occurs after eating or drinking, and this occurs as a result of gastric irritation of the vagus nerve endings. It also can be a symptom of diseases such as pleurisy, peritonitis, pericarditis, or uremia. In this our illustration, we can see a normal diaphragm and the glottis open, but here we are seeing a spasmodic contraction of the diaphragm that will be leading to the release of air into the lungs, and then the closure of the glottis that will now give rise to the hiccup sounds. The next thing we'll consider is paralysis of the diaphragm. This condition will arise as a result of crushing or sectioning of the phrenic nerve in the neck. Now here we're seeing the left phrenic nerve and we're seeing the right phrenic nerve. When the left or right phrenic nerve is sectioned at the level of the neck, it usually leads to paralysis of one side of the diaphragm. Occasionally, in the innervation of the diaphragm, we will see contribution from the 5th cervical spine, and when it makes contribution to the innervation of the diaphragm, we call this innervation as the accessory phrenic nerve, and this innervation is from the nerve that supplies the subclavius muscle, which has its root from the C5 spinal nerves. To obtain complete paralysis under these circumstances, the nerve to subclavius muscle will also be sectioned. Now here is the phrenic nerve coming down from the cervical plexus, and then here we see contribution from the nerve running to subclavius, giving rise to the accessory phrenic nerve carrying the C5 fibers. Before we end our lecture, we'll consider the last clinical correlate, which is penetrating injuries of the diaphragm. Any penetrating wound to the chest that is below the level of the nipple should be suspected of causing damage to the diaphragm until proved otherwise. In this illustration, we can see this stab wound that is below the level of the nipple. And one of the strongest queries will be damage to the diaphragm. This is where we end our lecture today on the diaphragm. If you have questions, if you have comments, suggestions, please drop them in the comment section. If you consider this material helpful, we encourage you to subscribe, like our video, and share it to your friends that it will also be helpful to. And together, we will build a unique anatomy family where we make anatomy simple.